Welcome all to the topic today on dialysis update, erythropoietin therapy in dialysis patients. So the topic will be, you all know that anemia, as Sir has already mentioned, it is a major cause of morbidity and mortality in dialysis patients. And the topic today will be discussed on anemia, the definition and mechanism, what are the treatment options, and erythropoietin stimulating agents, when to start, what is the target hemoglobin, when to stop, the adverse effects, and the trials. So anemia in CKD, as you all know, the definition of anemia in CKD is different from that of the general public, general population. So as per the 2012 KDIGO guidelines, the evaluation of anemia in CKD should begin when hemoglobin level is less than 12 gram per deciliter in females and less than 13 gram per deciliter in adult males. So what is the prevalence of anemia in CKD? Here you can see in the x-axis, we have CKD different stages, CKD stage 1 to 2, CKD stage 3, and CKD stage 4 and 5. And here the blue graph shows the prevalence of anemia. Here you can see that in the early stages of CKD, that is CKD stage 1 and 2, the prevalence is around 28%, but as it increases to CKD stage 3, it is 45%. And as it reaches to CKD stage 4 to 5, it increases to 75%. So the major cause of end-stage renal disease, we know it is due to diabetic nephropathy. And India being the diabetes capital of the world, we see a lot of patients in our dialysis center will be due to diabetic nephropathy. But we have many patients with non-diabetic end-stage renal disease as well. So let's see what is the prevalence of anemia in diabetes versus non-diabetic end-stage renal disease. So this graph shows the percentage of patients with anemia in diabetic versus non-diabetic. The dark shaded graph is for diabetic patients, and the lighter colored one is for non-diabetic patients. And here you can see that in patients with GFR less than 30, that is CKD stage 4 and 5, the prevalence is almost the same. There's around 52.4% for diabetic patients, whereas 50% for non-diabetic patients. So there is not much difference in the prevalence of anemia in diabetic versus non-diabetic end-stage renal disease. So let's see what are the common causes of anemia in CKD. So we have the topic for today is erythropoietin stimulating agents. So we know what is the importance of erythropoietin in anemia. So erythropoietin is produced by kidney, and it acts on the bone marrow to produce the red cell mass to correct anemia in a normal person. So what happens in CKD? In CKD, there will be reduction in the renal mass, as well as the diseased kidney won't be able to produce erythropoietin. But that is not the only reason why there could be anemia in CKD. So there are many other reasons why there could be anemia. The major causes are iron deficiency, then blood loss, reduced erythrocyte survival duration, then inflammation, infection, then underlying hematologic diseases, then hyperparathyroidism, hemolysis, nutritional deficits, etc. So along with that, we have to add underdialysis as well. So iron deficiency is a major problem in our patients. So if the importance of finding the other causes is, if we start erythropoietin stimulating agents alone, without correcting these factors, patient may not improve, hemoglobin may not improve. So that is the importance of correcting iron deficiency. Then blood loss. Many of our patients will be on antiplatelets. And if hemoglobin does not improve, we always have to rule out blood loss via GI tract. And the normal erythrocyte survival duration is less in CKD population. And inflammation and infection. CKD stage 5, CKD is a chronic inflammatory state. And what is the importance of this in the anemia, we'll see in the next coming slides. Then underlying hematologic diseases. So if there is we cannot always attribute anemia to CKD only, but there could be other cell lines are also involved, like leukopenia or thrombocytopenia, elevated ESR, or other hematological parameters, or other examination findings which point to other hematologic diseases. We always have to rule out hematologic malignancies, myeloma, leukemia, lymphoma, etc. Then hyperparathyroidism in dialysis patients and hemolysis also will contribute to anemia in CKD. The nutritional deficits like B12 and folate deficiency is also very important causes of anemia in CKD. So in the previous slide, we have told that there is a inflammation and infection. Due to the chronic inflammatory state in CKD itself, there will be production of hepcidin from the liver. So what does hepcidin do? Hepcidin will impair the iron utilization, iron absorption, and iron release. So iron stores in the reticuloendothelial cells, macrophages, and iron absorption are all impaired due to the presence of hepcidin. So the erythropoietin and serum iron are two major factors which are required for the stimulation of bone marrow to produce RBCs. So in the presence of chronic inflammation, presence of hepcidin, this will impair the release of serum iron, or it will impair the utilization and release of iron. So that is the reason why patient can have anemia. So chronic kidney disease, we have already mentioned blood loss, inflammation, reduced renal clearance, uremic toxins, then decreased EPO production. So all these are factors which will lead to the shortened RBC lifespan, then increased hepcidin, then iron deficiency, and anemia. So these are the three major points where we can act. One is ESA administration for decreased erythropoietin production, and HIF stabilizers in increased hepcidins, then iron administration in iron deficiency. So in a person with a normal person with whenever there is anemia, what will happen is there will be low oxygen carrying capacity of blood, and there will be decreased tissue oxygenation, and it will act as a sensor in the kidney for production of more erythropoietin by the activation of erythropoietin receptors, and kidney will increase the secretion of erythropoietin. And this increased EPO will stimulate the production of RBCs, and the RBCs level will come back to normal. That's how anemia is corrected. But in CKD patient, what will happen because of the decreased renal mass and the diseased damaged kidney and the accumulation of uremic toxins and all these factors, erythropoietin level is reduced, and there will be decreased stimulation to the bone marrow, and so the RBC production is reduced, and that will cause anemia, leading to other end organ damage as well, like heart failure. So we don't usually measure the erythropoietin levels to tell that erythropoietin deficiency is there. But we know that why we are not measuring is because there's a strong association between the erythropoietin deficiency in CKD. So this shows the anemic patient, the x-axis shows anemic patients, then non-CKD, stage 1 to 2, stage 3, and stage 4 to 5. And what is this dark colored graph shows the relative erythropoietin deficiency. From this, you can see that by stages 3, 4, and 5, there is significant reduction in the erythropoietin levels. This graph is important because it shows it has two graphs. One is the dotted one, and the lower one is the straight lines. The dotted one is the predicted erythropoietin level, and the lower one is the observed erythropoietin level. And in the x-axis, you can see the eGFR. Here it is coming down to less than 15, that is end-stage renal disease. So dialysis patients come in this group. So here you can see there is a huge gap between the observed and the predicted erythropoietin. See, the observed erythropoietin is here, but the predicted is here. So there is a huge gap. There is absolute erythropoietin deficiency in end-stage renal disease. So anemia, it's, as you know, it impairs the quality of life. It acts to the morbidity and mortality of a person. It causes many other end organ damage, like it can cause heart failure, respiratory failure, then fainting, fatigue, and whatnot. So how to evaluate anemia? So evaluation of anemia is very important. So whenever we have the patient with anemia, a CKD patient with anemia, we have to review the history, then do the basic RBC indices to see the size of the RBCs, whether it is a microcytic cell or a normocytic cell or a macrocytic cell. And usually anemia of a chronic kidney disease will be of anemia of, usually it will be of normocytic cell. But if there is concomitant iron deficiency or other vitamin B12 deficiency, it can vary. And also the ethnic background of a patient is also important, because even if the if patient has we have always have to keep in mind about thalassemia and other hemoglobinopathies like sickle cell anemia in patients with in patients from such background. So evaluation of other iron indices like low ferritin transferrin saturation is also very important in patients with iron deficiency anemia. And we always have to roll out iron deficiency and other vitamin B12 and folate deficiency in all these patients. Then iron deficiency anemia is once diagnosed, we have to plan the treatment accordingly. And apart from RBC indices, the reticulocyte count to roll out hemolysis, peripheral smear, then marrow study if indicated, as we have told already that if there is any other cell lines are also involved, like leukopenia or thrombocytopenia. We also have to roll out other hematological malignancies. Then iron step profiling is very important. Serum iron, total iron binding capacity, then percentage transferrin saturation, serum ferritin should be done. Then percentage transferrin saturation is find out by plasma iron divided by TIBC into 100. And all these are to identify how is the iron store and how is the whether the patient require iron supplement before initiating erythropoietin stimulating agents. Then folate and B12 levels should be checked. And occult blood and stool is important because GA loss could be a major reason why patient could have anemia. So, especially in patients on antiplatelets, or if there is no response to hemoglobin, no response of hemoglobin, even with the increasing adequate dose of erythropoietin stimulating agents and iron correction, then you have to rule out GA loss. So how often we can do the surveillance? So it all based on protocols used by the individual dialysis units. Usually we do hemoglobin monthly, and transferrin saturation and ferritin should be checked at least every 3 months. Then, but if there is any frequent testing is required, like recent blood loss, major surgical procedures, or if there is a response to IVR need to be assessed, we can do more frequent testing. This shows a comparison between men and women for a low iron indices in CKD. Low iron indices mean transferrin saturation less than 20%, or serum ferritin level less than 100 nanogram per ml. So here in the men, the range is up to around 58.8%, but in women it is much higher. Incidence of low iron index is much higher, that is around 72.8%. So what is the importance of TSAT, transferrin saturation and ferritin? So these are scenarios like hemoglobin less than 10 with transferrin saturation less than 30. So such patients, we know the iron store is depleted, and we have to give them iron until the saturation is increased. And if hemoglobin is less than 10, but saturation is more than 30, such patients are candidates for erythropoietin stimulating agents. If hemoglobin is more than 10, but saturation is less than 20% and ferritin is also on the lower side, such patients are likely to be iron deficient. And hemoglobin more than 10, saturation more than 20, and ferritin more than 200. They are not treated with, they have to be under follow-up. So we should avoid iron if there is active fungal infection or bacterial infection, or in patients who are iron overloaded, or history of hypersensitivity reactions. So what should we target is a serum ferritin up to more than 100 nanogram in non-dialysis patients, more than 200 in dialysis patients. Then transferrin saturation more than 20%, then hemoglobin of 11 gram per deciliter. And whenever hemoglobin is less than 9, we should redefine our treatment strategies. And in dialysis patients, there could be a functional iron deficiency state also. Functional iron deficiency state, it is because of the increased inflammation. There will be increased hepcidin level in the body due to the increased hepcidin production in the liver, and the reduced renal clearance of hepcidin, and due to the inflammation as such producing increased hepcidin. So all this, as I have said earlier, it will impair the iron absorption, tissue distribution, and recycling of iron. So there will be a functional iron deficiency state. It's like a reticuloendothelial blockade of iron distribution and use. So the treatment of renal anemia The 4 cornerstones of therapy are erythropoietin, iron therapy, adequate dialysis, and nutritional support. So the ESAs, the history starts before 1985. The gene for in 1985, the gene for erythropoietin was cloned. Erythropoietin was genetically engineered, and by 1986, first study of erythropoietin in renal anemia was reported. And initially, the studies of ESAs in cancer-related anemia was published in 1990. And the cancer, as you know, it requires a lot of blood transfusions, and ESAs were an attractive alternative. So ESAs were approved in Europe for treatment of cisplatin-related anemia in 1994. Then by 2000 to 2002, ESAs were approved for all chemotherapy-related anemia. But later we got some issues. By 2007, black box warning, because by 2005, there was an early data of increased mortality in cancer patients. So by 2007, there was a black box warning, safety labeling. And by 2008, FDA warned about increased risk of cancer, thrombosis, and hence to lower the target of hemoglobin to 10 to 12 gram per deciliter. And then thereafter, it was kept average hemoglobin 11.5 to 12 gram per deciliter, and average monthly epoetin alpha dose to 17,500 unit per week. So 2011, there was more conservative dosing recommendations from FDA to upper limit of hemoglobin to 11 gram per deciliter. And then by 2012, average hemoglobin around 10 to 11 gram per deciliter. So what are the benefits of ESAs? The cardiovascular benefits because of ESAs are reduced heart rate and stroke volume, reduction in the high cardiac output, reduced anginal episodes and myocardial ischemia, regression of left ventricular hypertrophy, then stabilization of left ventricular dilatation, and there will be increase in the whole blood viscosity. What are the non-cardiovascular benefits of ESAs? They also reduces the need for blood transfusion first and foremost, and improves the quality of life symptoms, improves the exercise tolerance, improves immune function, nutrition, etc. To the specific erythropoietin stimulating agents, it is formed by a recombinant technology, gene transfer into mammalian cell line Chinese hamster ovary cells. The initial was a 165 amino acid backbone with 1 O-linked and 3 N-linked glycosylation. There are first generation, second generation, and third generation molecules. First generations are mainly epoetin alpha and beta. It is a minor change with polysorbate 80 in epoetin alpha and polysorbate 20 in epoetin beta. The darbepoetin alpha is a second generation molecule, and the third generation is methoxypolyethylene glycol epoetin beta, or continuous erythropoietin receptor activator called SERA. So epoetin alpha or beta, its half-life is 8.5 hours. It could be given either IV or subcutaneous. The bioavailability of subcutaneous is around 20 to 30%. So these are the commonest, one among the commonest drugs which is used in dialysis unit. And bioavailability of intraperitoneal is too low. So intraperitoneal administration is not advisable in PD patients. Darbepoetin alpha, it is second generation, has 2 extra N-linked chains, which gives the extra duration of action. That's half-life is around 25.3 hours. When we compare with erythropoietin alpha, it is only 8.5 hours, whereas for darbepoetin alpha, it is 25.3 hours. It has a lower clearance rate. So it could be administered less frequently, like once in 1 or 2 weeks. The SERA or continuous erythropoietin receptor activator, it is a pegylated derivative. Its half-life is much more. It is 130 hours. So usually it could be given once monthly, either IV or subcutaneously. So these are the 3 different generation of molecules of erythropoietin stimulating agents. This is another molecule called peginacetide. It is a EPO mimetic peptide, but it is not related to EPO at all. But it was used to treat for anti-EPO antibody mediated pure red cell aplasia. It was in the market for a very short time, but it was withdrawn due to severe anaphylactic reactions. It's not available. And we have told about hypoxia-inducible factors, hepcidin, etc. And there are some orally available agents also, which can increase, which are used as HIF stabilizers, hypoxia-inducible factor stabilizers, which increase the endogenous EPO production. The orally active agents are roxadustat, daprodustat, vadadustat, and molidustat. So when we compare the ESAs, half-life in IV, or we have to compare the two different types of administration. One is IV and second is subcutaneous. So what is the difference in the half-life? So let's check the first generation molecules, epoetin alpha and beta. So epoetin alpha, the mean half-life with IV is 6.8 hours, whereas for subcutaneous, it is almost 3 times, 19.4 hours. Epoetin beta, it's 8.8 hours for sub-IV and 24.2 for 2 hours for subcutaneous administration. Then darbepoetin alpha, the half-life is 25.3 hours, and for subcutaneous, it is 48.8 hours. Then say methoxypolyethylene glycol epoetin beta or SERA, the IV and subcutaneous half-life is almost similar, and it is 134 and 139 hours. So almost similar. All these FDA approved agents and epoetin B's, all these are FDA approved agents. Then initiation of ESAs. First and foremost, we have to exclude other causes of anemia. What we have to remember is if we start erythropoietin stimulating agents without looking for the other causes of anemia or without addressing the other causes of anemia, patient can have hyporesponsiveness. So always we have to exclude other causes of anemia. Then hemoglobin level at which ESA to be started is usually by 9 gram per deciliter and target up to 11 gram per deciliter. And for erythropoietin, the starting dose is 25 to 50 IU per kg. Darbepoetin 20 to 30 microgram once weekly. And for SERA, 30 to 60 microgram once in 2 weeks. We should usually give once in a month also. So this is dose. This chart shows the dose equivalence. That is when we have to convert from or switch from one agent to another, like epoetin beta to darbepoetin or SERA. What is the equivalent dose roughly? So if patient is on like 4,000 unit epoetin beta per week, you can switch to around 20 microgram darbepoetin or SERA of about 75 microgram per month. So that will give you a rough idea about how to switch from one agent to another. As you can see, the dosing frequency is very less. For SERA, it is only once a month. So when we are talking about the good things about ESAs, is it devoid of side effects? Because we have seen in the previous trials, what are the problems with erythropoietin stimulating agents? What are the major side effects? So major side effects are, one is hypertension. We all know that hypertension is a major cause for major reason, adverse effect of erythropoietin stimulating agents. Then there are some other causes, other problems like seizure, then potential risk of cancer progression, thromboembolic complications like stroke, cardiovascular events, venous thrombosis. Then minor side effects are infection, myalgia, headache, diarrhea, etc. So what is the reason for erythropoietin induced hypertension? Why it causes erythropoietin causes hypertension? So the major reasons for erythropoietin induced hypertension is, one is vasoconstriction of resistance vessels, then platelet aggregability, increased levels of endothelin 1s and constrictor prostaglandins, and or inhibition of acetylcholine mediated vasodilatation, then calcium influx in the smooth muscle cells of vasculature. So all these are different mechanisms by which erythropoietin can cause hypertension. And what is the other adverse effects? One is increased cardiovascular risk. So increased blood viscosity due to the erythropoietin and the direct effect of erythropoietin itself, or the oxidative stress from the intravenous iron, or increased blood pressure. Then as you know, in patients with large weight gain, there will be post-dialysis hemoconcentration. So all these will act to cause increased cardiovascular risk in patients on erythropoietin stimulating agents. So this shows a comparison between methoxypolyethylene glycol epoetin beta and epoetin alpha among the complication levels. So then fistula thrombosis and local pain or tissue reaction, where almost nil in early group and early first generation groups, whereas with third generation it's around 3%. Then incidence of blood transfusion is almost comparable with 2. And diarrhea and flu-like symptoms were seen in more in first generation groups rather than third generation group. So earlier, when we talked about the history of erythropoietin stimulating agents, we told the initial happiness of using erythropoietin stimulating agents for to reduce the incidence of blood transfusion in cancer patients were not long lasting. We had to introduce a black box warning telling that we have to reduce the level of usage of erythropoietin stimulating agents in cancer patients. What is the reason? These are the different trials which were used, and the studies which were done in cancer patients, and with use of erythropoietin stimulating agents, what was the adverse outcomes? So you can see they were especially head and neck cancer, metastatic breast cancer, metastatic non-small cell lung cancer, then head and neck cancer. These were the different types of cancers, patients in which erythropoietin were used. And mainly it was erythropoietin beta and dabipoietin alpha. Erythropoietin alpha, beta, or the first and second generation erythropoietin were used. You can see the target hemoglobin was always on the higher level, like more than 13 or then 14 to 15.5, 12 to 14, etc. And the adverse outcomes were more. So these are some of the studies by which we had to stop. And these are not the only studies by which we had to stop it. Then we'll see that later. Then hyporesponsiveness to ESA is one thing that a patient, what we expect with erythropoietin stimulating agents is within a month there should be a significant increase in hemoglobin level. But what is hyporesponsiveness? It's defined that hemoglobin does not increase from baseline after 1 month of appropriate dose. And we had to increase more than 50% increase in dose requirement of ESA. So compared to a CKD patient who responds to erythropoietin stimulating agents, a person who has decreased response has a bad prognosis. And always, if there is hyporesponsiveness, we have to go back and check whether there is any other missed cause of anemia other than the erythropoietin other than CKD itself. So ESA resistance, when requirement is greater than very high doses of erythropoietin stimulating agents, then you have to consider it as ESA resistance, like 300 to 500 units per kg per week. Then you have to think about erythropoietin stimulating agent resistance in such patients. So cause of hyperresponsiveness to ESA therapy. So it means whenever, even if we give higher optimum dose or with repeated escalations, the patient is not responding and anemia is not getting corrected and patient requires blood transfusions. So such cases is mainly due to iron deficiency, inflammation, then under dialysis. So here adequacy of dialysis is very important in all patients who are on erythropoietin stimulating agents. If not responding well, we always have to check the adequacy of dialysis. The less common factors will be B12 and folate deficiency, blood loss, then marrow disorders, and poor compliance. Then transport issues, whether they are preserving the cold chain, all these factors are also important. Then other rare causes will be anti-EPO antibodies. Then always rule out hemoglobinopathy, then use of AC inhibitors and ARBs, then hyperparathyroidism. All these can contribute to hyporesponsiveness to ESA therapy. So this is a situation, EPO-induced pure red cell aplasia leading to persistent anemia. This chart is interesting because see, you can see that this patient has hemoglobin level is given in the y-axis and the time of months is given in the x-axis. You can see the follow-up of 1.5 years. And here the patient was initially on epoetin alpha when his hemoglobin was maintained between apparently around 11, and epoetin alpha sub-Q 50 IU per kg per week was continued. And after 6 months, you can see it was changed to, dose was changed to 75 IU per kg per week. Anyway, the hemoglobin remains the same for all these 6 months, and then it was increased to 75 IU per kg per week from 50. And by around 12 months, there was after 9 months itself, there was a reduction in the hemoglobin despite the rise in epoetin alpha dose. And it has come to a low level of hemoglobin of around 6 gram per deciliter from 11. So 11 to 6, there is a steep fall of hemoglobin. So the bone marrow was done and it's showing pure red cell aplasia. And this time patient was requiring transfusion of 6 packed RBCs per month on average, and presence of anti-EPO antibodies. So this is important because if patient, despite the use of high dose, if patient has significant sudden drop in hemoglobin without any other obvious reasons, we can consider presence of anti-EPO antibodies and further test to note if there is any pure red cell aplasia. So we have told earlier why there was a low target hemoglobin and why. So all these and what is the risk of erythropoietin stimulating agents. What all these were identified by the landmark trials in anemia and kidney disease. So from 1998 to 2019, we have many trials on anemia in CKD. And first is the normal hematocrit trial, which was done in 1998. Then QUIET trial and CREATE in 2006. So CREATE was also in non-end-stage renal disease CKD patients, and the target between it was a higher hemoglobin levels and adverse cardiovascular outcome was studied by that trial. Then QUIET trial also, it was a higher hemoglobin versus primary composite outcome, including stroke. Then there was another trial called TREAT in 2009, which goal of hemoglobin was kept as 30. Which showed increased risk of stroke and venous thromboembolism in patients with higher hemoglobin level on erythropoietin stimulating agents. So this is the comparison of these three trials, QUIET, CREATE, and TREAT. And here you can see the all populations where hemoglobin chronic kidney disease stage 5 patients. Then these are all CKD patients, but not necessarily CKD stage 5. Hemoglobin target was kept as 13.5 high versus low or optimum, 13.5 versus 11.3 gram per deciliter. And for CREATE also 13 versus 11 gram per deciliter, and TREAT also 13 versus 9 gram per deciliter. But targets were not achieved in many because of the primary outcome where a composite of death, MI, hospitalization for chronic heart failure, stroke, etc. was very high in higher hemoglobin group. So since due to the increased risk of primary outcome, this hemoglobin target level was reduced. So this shows we have been talking about the first generation and second generation and third generation erythropoietin stimulating agents. And just to refresh, first generation erythropoietin alpha and beta, second generation darbepoetin, and the third generation methoxypolyethylene glycoepoetin beta. Since it is a new molecule, so let's consider and let's compare what is the cardiovascular safety and all-cause mortality of SERA in anemia of chronic kidney disease. So this is a multi-center, open-label, randomized, non-inferiority trial done in CKD patients with adequate iron stores with a median follow-up of 3.4 years. And the comparison was between patients were randomized into two groups. A group of almost similar, that for methoxypolyethylene glycol 45.4% and 45.7%. And the conclusion was in patients with all-cause mortality was almost similar. In patients with anemia of CKD, once monthly SERA was non-inferior to conventional erythropoietin stimulating agents with respect to cardiovascular events or all-cause mortality was the outcome of this study. So this is another study which shows the oral, I've told earlier about oral agents which are available, which are HIF stabilizers, hypoxia-inducible factor stabilizers like daprodustat. So it versus darbepoetin alpha, whether it is equally effective or not. So this trial was done in Japan between 271 hemodialysis patients with between darbepoetin alpha and daprodustat, and 1 year follow-up. The serious adverse events were 27% versus 15%. So oral daprodustat was non-inferior to darbepoetin alpha as measured by mean hemoglobin over weeks 40 to 52. So only the cost is the factor, a hindering factor. Otherwise, it is a good molecule. So this is another study published in Journal of American Society of Nephrology. among the type of erythropoietin stimulating agents and mortality among patients undergoing hemodialysis. So it is a large study, a nationwide cohort study in Japan. Undergoing a number of patients were around 2 lakhs. It was a 2-year follow between short-acting ESAs and long-acting ESAs. So here short-acting ESAs means epoetin alpha and beta, and long-acting darbepoetin and epoetin beta. Then the conclusion was long-acting ESA use might be associated with a higher rate of death than short-acting ESA use among patients undergoing hemodialysis. That was the conclusion based on this study. So the long-acting ESA use was associated with increased rate of cardiovascular death, including death from cardiac disease and stroke, and rate of non-cardiovascular death, and in particular death due to malignancy and infectious diseases was also elevated in the long-acting ESA users based on this study. So now from this, we can conclude that why a low hemoglobin target in ESRD. So based on these trials, we have understood that high hemoglobin level is causing more risk than benefit. That's why patients, we are keeping a low target of 11 gram per deciliter. So as we go the hemoglobin, as we go from 8 to 14, there is increased risk without additional benefits in patients. And so between 10 to 11 will be the optimum level to keep the hemoglobin. So the take home points, anemia is very common in CKD. Iron deficiency and EPO deficiency are major causes, but we should not forget about the other nutritional deficiencies or other hemoglobinopathies or other rollout hematologic malignancies or GI loss of blood in patients with anemia, especially if we don't see the desired response of hemoglobin even after initiating or escalating erythropoietin level, erythropoietin doses. So always we should rule out other underlying causes or other concomitant causes which can contribute to anemia. And patients require monitoring of iron indices. And before starting ESAs, always we should ensure that iron deficiency is properly corrected and iron stores are repleted, because proper iron management is important for the success of erythropoietin stimulating agent therapy. And we cannot always stop it, or what we can do is we'll be able to titrate the dose, up titrate and down titrate the dose of erythropoietin stimulating agents in dialysis patients to maintain an optimum hemoglobin level of 11 gram per deciliter. So whenever patients, if patient can, in affordable patients, or we can try to give third generation molecules to have this, which have longer duration of action, and orally active agents are also available, but the cost is a factor. So considering or treating anemia is very important in CKD patients for the improvement of the quality of life and to decrease the morbidity and mortality. So the three major things are then patients should have proper dialysis. Under dialysis is another common issue. So always we should check the adequacy of dialysis and whether patient is patient is getting adequately dialyzed or not is a very important factor. Then iron stores and ESA. These are the optimal. These are the three cornerstones of optimal anemia management. Thank you all for the patient listening.